Good morning, dear colleagues and dear students. Today we are going to talk about abnormal wound healing. I'm Dr. Hany Saad. I'm Assistant Professor of Plastic and Reconstructive Surgery in Shams University. First of all, we got to know that God heals and the doctor takes the fees. This is by Benjamin Franklin, and he means that we have to do all what we have to do to heal the patient and to take the fees from him, but actually God heals him and not us. First of all, we would like to introduce the definitions of a wound. A wound is a disruption of a normal structure and function of the skin and underlying structures. It usually happens following a trauma, where the skin is the predominantly affected, although any tissue, whether nerve or bone or organ, may be wounded, but it's always the skin is the predominantly affected. Wound can be classified into open and closed wounds. First of all, we talk about the open wounds. The first of it, the abrasions, where the superficial layer of the skin is removed, as shown in front of you. The skin, knee or elbow and rope burns are very common examples that happens to daily life activities. It's actually due to friction. Number two, we have got the lacerations, where direct cuts and there is masses of torn tissue underneath, caused by dull knife, bone fragments, and machinery, and may include crushing as well, as shown in front of you. Number three, we have got the puncture injury, where sharp penetrations, either caused by needles, nails, bullets, wires, as shown in front of you. And then we have got a vulgin, where the section of the skin is totally torn, either into part attached to the body or totally detached from the body, as shown here in the ring finger is totally degloved and avulsed. And then we have got the amputations. It's removal of a limb or a digit from the body. Then we come to closed wounds, where the major cause is a blunt force trauma that may cause the closed wounds or contusions, where the skin appears to be totally intact but still suffer from damage to the underlying tissue, as they show in the photo with the black eye of this man. Then we come to the phases of wound healing and what's meant by wound healing. Wound healing is a physiological process by which the body replaces and restores the function of a damaged tissue. It's a systematic process actually. It's composed of inflammatory phase, the proliferative phase, and the maturation phase. We have got types of wound healing. Primary intention, where in all the tissues, including the skin, are closed with suture materials after completion of the operation. And this happens actually in any operation we perform. Secondary intention, where the wound is left open. We don't interfere and leave it to close naturally. And tertiary intention, in which the wound is left open for a few days and then it's closed whenever it's found clean. We have got some differences between the primary and secondary intention, where the large scab formation, more intense inflammation, much amounts of granulation tissue form, and wound contraction. Here's showing some way how the phases of wound healing happened. We start step by step until we reach the maturation phase. The inflammatory process, it always persists about 1 to 4 days. The inflammatory phase, how it happens after the injury, there's about 5 to 10 minutes period of vasoconstriction to slow down the blood flow, then it's followed by active vasodilatation. Endothelial cells swell, increase in permeability of the vessels. It's actually caused by the histamine effect. And then the process of chemotaxis and cell migration happens. It's the major component of the granulation tissue. It actually helps the healing and promotes the adhesion and migration of neutrophils, fibroblasts, monocytes, and endothelial cells into the wound itself. Then we have got the second phase, proliferative phase. It starts from day 4 to second week or to the third week. It starts on the second or third day and lasts approximately 2 to 4 weeks, where the fibroblasts begin to move into the wound and they produce major substances which are essential for wound healing, what's called matrix formation. And then the process of angiogenesis, where large number of capillaries are growing into the wound itself. And then process of phagocytosis, where abundant macrophages are invited to the wound. Then the process of epithelial migration. It actually happens, epithelial migration, closure of the wound, how it happens with the concept of loss of contact inhibition between the epithelial cells of the skin, and migration, proliferation of the epithelial cells centrally for the action of wound closure. And then phase of remodeling. Remodeling, it takes from the third, fourth week up to 2 years. It begins approximately 3 weeks to 4 weeks after injury, up to 1 to 2 years. At that time, collagen synthesis and degradation are accelerated, and a large number of capillaries will be growing into the wound. That happens will regress and disappear. And then type 3 collagen laid down early in the wound healing is replaced by type 1 collagen until the ratio of 4 to 1, type 1 to type 3 is obtained within the wound site, where we have got the peak tensile strength at 60 days, where we gain about 80% of the tensile strength of the pre-injury activity. Here's a summary of what happens: hemostasis, inflammation, connective tissue regeneration, and contracture. Hemostasis, it stops bleeding. Inflammation, chemotaxis, and the inflammatory process happens. The connective tissue regeneration, epithelial migration, proliferation, maturation, contracture. This is the proliferative regenerative phase. And finally, the maturation phase with the contracture, scarring, or remodeling of the scar. There are many factors that affect wound healing, either general factors or local factors. The general factors include the age, the skin type, comorbidities, nutritional deficiency, where vitamins A and C and E are the most essential in wound healing, drugs, whether smoking or not, where local affection of the wound healing depends mainly on the local wound, where there is an infection, there is moisture in the wound is exposed to irradiation, the wound is chronic, it lasts for a long time, there is foreign body in the wound. All these factors affect wound healing. A preferred scar is one that has matured rapidly without contracture or increase in the width and without forming more collagen that is necessary for its strength. That's what we call a preferred scar, the ideal scar. We have got some examples here. We have got linear scars in the neck after thyroidectomy. We have got linear scars in the back of the head. We have got linear scars in the arm. What about abnormal wound healing? Abnormal wound healing includes either it's delayed, it's a chronic wound, it doesn't close, it's more than 6 month wound. Or we have got the contrary, excessive tissue formation, hypertrophic scars, keloids, contracture, malignant ulcer at the end even. What's an ulcer? The raw area. We should always talk about the site, the size, the shape, the floor, the base, the margins of the ulcer, the surrounding tissue, the underlying structures, and the draining lymph nodes. First of all, this is abnormal wound healing about the keloids and hypertrophic scar, where it's characterized by an accumulation of excess collagen from either increased collagen synthesis or a process of decreased collagen degeneration. The scars still remain immature with abnormal high content of type 3 collagen, and therefore a disorganized pattern of collagen deposition in the wound. Here's some examples of the keloids of the ear. You see how it looks like it's beyond the margins of the wound and is growing. You see here the other diagram showing the overgrowth of scar tissue, a keloid. Keloids beyond the borders of the original wound. They don't tend to resolve spontaneously. They keep growing. It can form at last as a year after injury. They may be at the first of the wound, there is no evidence of keloid, then it starts to grow eventually. Keloids has significant familial tendency. Actually, it's common in young age and dark colored skins. The sites of the keloids, they are more common in the deltoid area, the parasternal side, the ear. It's very rare in the palm and the sole of the foot. They are frequently resistant to treatment, usually recurs after surgical excision. Whereas the hypertrophic scar, there's some examples as you see in front of you. They stay within the limit of the original wound. They tend to regress spontaneously, opposite the keloid. They appear very soon after the tissue injury. They are more commonly than the keloid, but they are more responsive to treatment. They may need a single optimal treatment or multiple treatments. Recurrence is very high in keloids. Scar usually look the worst between 2 weeks and 2 months. Therefore, they should be revised until maturation unless associated with contracture. Surgical management is preserved for cases that are not responsive to other conservative managements. The conservative managements include, as you see, intralesional corticosteroid injection for regulation of the collagen metabolism. They may use laser, the fractional laser, and silicone or silastic sheets. Pressure garments as well is thought to decrease the tissue metabolism and increase the collagenase activity within the wound. The use of pressure requires patience and perseverance, as continuous application for at least 4 to 6 months to reach a satisfactory result. Radiotherapy is other modality of treatment, and it's reserved for intractable cases of keloids and is best used in conjunction with surgical excision. That's to say, we should do surgical excision and then start the radiotherapy. And then we have got the scar with contractures. As you see, this happens in open wounds in either post-irradiation, post-burn, post-exposed areas after trauma. As you see, contracture in the neck, contracture in the elbow joint, contracture in the hand. And at last, the malignant changes that may happen to the wound. They are called the marjolin ulcers. Thank you.